Couple of things I wanted to point out in John's talk earlier. When you look at data and information, sometimes a lot of the things that come with supplemental, medications can be of value. Years ago, in this symposium, I did a lipid thing on non-statin related therapies for lipid reduction. There was one study that looked at 8 individuals with cinnamon with a 1% lowering of LDL cholesterol. So that would amount to a relative risk reduction of like 0.0005%. And yet people take cinnamon. The garlic one, y'all know garlic. I can't remember the name of the guy that does the late night TV programs. Used to be radio, they always had garlic all the time. And after having his 5-vessel bypass and 15 stents, Larry something. Really old looking guy. But anyway, yeah, it didn't help him. But garlic too, garlic in fairly high quantities, powdered garlic, crushed, preserved, put in capsules, had about a 1% lowering of LDL cholesterol, which again, relative risk reduction is going to be minimal compared to other different therapies. They actually looked at one recently. There was a study, and I'm not touting one medicine versus the other or anything, but looked at people who went on a diet, what they felt was a prudent diet, and then they did, Metamucil, or they did all of those other things, or took cholesterol off, and they did whatever they felt in their own mind was going to be helpful. And they looked at LDL reductions versus 5 milligrams of rosuvastatin, which is a low dose that nobody ever uses because it's not, if you have coronary disease, it's not an intense dose statin. So you looked at do everything that you think that you can do to lower your cholesterol, diet, exercise, and everything versus 5 milligrams of rosuvastatin. And LDL lowering was 3 milligrams per deciliter in the other group, and 35% decrease in LDL cholesterol with 5 milligrams of rosuvastatin. And I think, to John's point, you do have the occasional person who's really highly motivated, and when we see somebody who comes in and says, I've read the literature, I've looked at this, I've seen that, and everything else, great. Jump on it and say, you go do you and investigate all you want and do what you want to do. But still, the vast majority of people in our practice anyway, I think in order to get any benefit whatsoever from anything is probably going to require some sort of pharmacological therapy. But anyway, are you ready?
I'm ready.
All right. Dr. Schabauer, you've been here since? 1996.
Yeah, we met in 95.
Dr. Schabauer and I went to the same high school in Mitchell. I just was back there visiting family. Of course, they're all in the cemetery, but I drove by Dr. Schabauer's house, took a picture, texted it to him. But anyway, you went to school at Madison, Wisconsin? Oh, Northwestern for undergrad, Madison for medical school, and residency in internal medicine, and then Mayo's for cardiology, and spent some time in Florida, because that's where actually we probably met more for the first time at the swimming pool at the ACC.
Orlando conference, yeah.
Yes. And so, yep, like I said, he's been here for quite a long time, and he's going to give us a cardiovascular update.
Thank you.
Alex?
I'll try to be quick. So we're about, 10 minutes off, so we've got a long lunch break. Believe it or not, we did that on purpose, so. All right, so this is just a butterfly in the front yard. So we're going to do updates. Drew and I have been doing this for a little while. I usually get positive feedback. I'm going to talk fast. I'm not going to explain everything on the slides. I just want to get what we tend to call in medicine those Augenblicks, things that'll maybe stick out in your head. So a long way up and a long way down. We're going to do this correlating to a trip, as I usually do. Start off with some grandkids. That's Nora, that's Malachi, that's Noah. Okay, disclosures, none in several languages. The bottom one is Finnish. That one always looks funny to me. Here's our committee. First of all, I'd like to have anybody on our committee stand up if we have any of these members in the room. So Dr. Purdy, Cece, Diane, whoever's here, stand up. Let's give them all a round of applause. And many people are also out there, so Teresa's already standing back there, so that doesn't count. Okay, Jonathan, are you in here? Did you stand? Yeah. You did? Okay, good. I missed you. Sorry. Michelle's back there. All good. So this is a picture of a glacier in Jasper Park in Banff, Canada area, and I visited that glacier a long time ago and again recently, and it's a lot smaller than it used to be. Just saying. And this one is quite impressive as well. Okay, first thing we're going to talk about is the study that Dr. Hatton-Ellis was talking about with bempedoic acid or Nexletol. As he already mentioned, I won't spend much time on this. It's not a statin. It works through a different mechanism. It inhibits cholesterol synthesis. It lowers LDL. Is unlikely to affect the liver. Does not have a significant myopathy rate. It's 100 milligrams a day. It's been in Europe for years. And it's a reasonable alternative. Unfortunately, now that we have patents here, it's not cheap. So, of course, it has to cost money. If you're a chemistry nerd, so Holly or any of the pharmacists in here, you can dissect that all you want, but that's the chemical structure. In 3 dimensions, it makes a horseshoe if you're interested. So the CLEAR Outcomes trial is what we're talking about. I don't know if my pointer shows up. Yes, it does. So the brief thing to look at is our 4-component MACE, 3-component MACE. It looks like it does better, but as Dr. Hatton-Ellis pointed out, these are absolute risk reductions of 1.3 and 1.6%. So you need whatever, 80 people or 70 people to 1 to actually have a huge benefit. It's an alternative to a statin in that regard. Secondary endpoints, non-fatal, fatal MI, coronary revascularization, again, absolute risk reductions 1.1 to 1.4%. Our statins are usually in the 3% range, so it's not as good as a statin. Stroke, unstable angina, hospitalization, that one looks like it's doing fairly well, not a huge statistical difference. Death, it didn't make a big difference. All-cause mortality didn't make a big difference. There's a few things to pull together on this. So you don't have more diabetes as you might have with some of the other drugs compared to a placebo. Muscle disorders we don't see. The only thing we see a little bit more of is some renal changes, maybe gout, but I'm not sure that's statistically significant. Same thing with gallstones. So it's pretty benign. The key thing I wanted to show you on this slide is that the age group that seemed to be statistically significant, again, these bar graphs, you want to have it not touch the midline to be significant, is the greater than 65, less than 75 group. Probably better for men than women. Secondary prevention, it touches the line of identity, but in primary prevention, as Dr. Hatton-Ellis reviewed, that's relevant. Not super effective when your LDL is 160. But again, those people, I think the power of the drug just isn't enough to help us much. So if you have more of your ordinary LDL 120 to, or what is that, 130 to 160, it'll make a bit of a difference. Diabetics, it probably has some benefit. So those are the peoples very specifically. As we get into what we call precise medicine, this is probably what's going to make a difference for us. Conclusions. Probably gives us, again, relative risk reduction, which they like to market to, a 22% change in LDLs and also the inflammatory marker CRP. But from a standpoint of absolute risk reductions, we're down at the 1 to 2% range. So again, it is what it is. But for those patients, as everybody's been talking about all day, who you could spend, whether you spend 2 minutes and write a referral to Tamara, or whether you spend 20 minutes trying to brainwash them into the notion they need to change their life, ultimately they just want to have a hamburger and have them give you a pill. So here's your pill for if you want to try something, then they don't tolerate statins. Yeah, so I'll skip that. Okay, now we're on the road going up to Yukon. And that's in Yukon. Okay, so this is the next topic, so we're already switching topics. Venous congestion, you know, everybody in the room probably knows I do cardiology as well as vascular medicine, and I particularly also do a lot of venous work. So I wanted to talk a little bit about how this all happens, and I love this particular graphic on the right-hand side here. When you look at the left ventricle, we have this blood pressure of 120, and then it drops down to like 5, and that's how the ventricle functions. It's our big pumping chamber. But as you move along into the aorta, you have our more normal arterial blood pressure. But then as you go to large arteries, you get this rebound thing where the pressure actually has an extra little bump in it because it's an elastic vessel. Then you get to the smaller arteries, which is where we're measuring our arm blood pressure. It's usually, or leg for that matter, but that's a different story. As you get down to the arterioles, notice the pressure starts dropping and it's not as pulsatile. Our body actually doesn't like to have pulsatile flow at the capillary level. It's really more in the arterial level. So as you get down into the capillaries, it's notable that the pressure starts falling as you move along and it's not pulsatile. But look at where the pressure is. It's down at like 4, okay? And it may go up to 20, it depends on the circumstances. But nonetheless, our absolute flow into our body is functioning in this 4 to 20. That's where all the tissue oxygenation, nutrition comes from. And then when you get back out to the venous side, notice the venous pressures are supposed to be way down here, okay? So we're going to talk about that more in a minute. We're going to do a little physiology lesson before I get into one of our major topics. As you stretch these tissues, particularly on the venous side, the capillary side, etc., you get a release of endothelin-1 and interleukin-6, which are both inflammatory agents. The next thing that's interesting about that is how quickly that happens. When you do a study and you look at endothelin-1, within 20, 60, 120 minutes of adding venous congestion, you already get release of these inflammatory markers. So when you have a patient who's edematous, it's causing inflammation, and we're going to talk about why that matters. Most of them, you know, they lay in bed, they're doing fine, they get up in the morning, and within an hour, this is already underway. And you'll often hear us talk about that in terms of how quickly people swell and how bad that is for them. So venous and tissue congestion is an independent stimulus for these issues causing inflammation. I always like that number 2. About 35% of our body mass is our limbs, so that's quite a bit if you think about it. Some of our patients, it's 50%. So this is always fun. So you have these guys. I've always wondered how this works. You're standing there in front of the palace, and they stand perfectly still. I can't imagine what these people look like as a patient 20 years later. I mean, nothing good can come of this because they're standing perfectly still, and those pressures, which are supposed to be cycling with calf pumping down, 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 they just stand there at this high pressure. So yeah, maybe they should give them a relief every hour or so, let them hang upside down in the back. Or maybe they do, because I think they're only on for an hour or 2 at a time. So maybe they go in back and hang upside down. I don't know. So that's interesting. So this is just a graphic to demonstrate that concept, that you have venous congestion. It creates a cycle that makes your cardiac index drop, increases your kidney response to that, which then gives you water retention, salt retention, and ultimately volume expansion, which actually just makes the venous congestion worse. So congestion begets congestion. It's an important cycle, and we're in the job of trying to fix that. So renal tamponade, this is a great one. How many times have we seen somebody come in, their creatinine is 2.8, they look like they're in renal failure maybe, but they're actually in heart failure, and we give them a diuretic, and 3 days later their creatinine is 1.8. Anybody seen that? Yay, I think we've all seen it actually. So that's because when your venous system gets so congested, the nephrons can't really do their work anymore. And if we don't understand the concepts of cardiac tamponade, or like a compartment syndrome in a leg, when you have, you know, a traumatic injury to a leg, it's the same concept. You're tamponading the ability of flow to cross through the renal perfusion. So keep that in mind physiologically. What else gets congested? So we know we have big livers in these people. They ultimately end up with some cirrhosis. When they get portal hypertension, which congests the whole gut system, as well as the liver and the spleen. So when you do the physical exam, which hopefully people actually do a physical exam these days, they'll find a big liver, they find maybe a pulsatile liver, they get a big spleen. Ultimately, where that really matters is, again, you give them a pill, and their gut is edematous. You've probably seen this before, where someone has a little bit of ascites, or they're otherwise just congested and bloated. You give them all the diuretic pills you want, Bumex, Lasix, 100 milligrams, 160 milligrams, whatever, doesn't do a thing. You give them an IV dose, boom, it works, okay? So their gut won't absorb pills, but also they end up with low albumin because they're not absorbing their nutrition. So don't forget, if you have a heart failure patient or somebody else who's congested, you really need to work with their nutrition. It's a good idea to get dietitians involved. A simple cheat is obviously IV albumin to kind of give them a boost to move some of their fluid out of the third space into their circulation. Otherwise, if you give them boost supplements or Ensure or something like that, the protein size of the nutritional protein in that is supposed to be smaller. That's what they tell me anyway. So I think it probably is more likely to cross over the gut barriers and actually become reasonable nutrition. So just don't forget about nutrition in these people. And I'll show you a picture about that here shortly. So RV rather than LV dysfunction, so right-sided congestion, is often what's associated with cardiac cachexia. I don't know if anybody's ever seen a patient like this before where their ribs are showing and their pacemaker is popping out like it's ready to just be pulled out of their skin. That's, again, a nutritional issue, and it has a lot more to do with the right side of the heart than the left side of the heart. Obviously, if you have left-sided failure, you're going to get pulmonary edema, you're going to get some right-sided failure, but it really is the right side of the heart and the circulation that causes more cachexia. It's nutritional. It's inability to move around. Okay, so now we're going up a little further. We hit Alaska. Good job. Okay, now to that end, there was a recent study on something that has bugged me for all of my medical career, and that is tricuspid valve regurgitation and what it does to people. For years, we've known that so tricuspid valve, kind of the least important valve of the heart, there's never been a surgeon who would find data to demonstrate doing an open heart surgery to fix tricuspid valve regurgitation to be beneficial. The risk-benefit ratio is not there, but they're miserable. They look like that last picture I showed you. They're cachectic, they have ascites, they have swollen legs, swollen thighs, swollen feet. Sometimes the men will even have swollen genitalia. You've probably all seen these things on the wards or in your practice, and they're miserable people, and yet nobody will operate on them. So we've been waiting a long time for this Triluminate study to maybe give us an option. And this has been done off-label through the MitraClip system for a little while, and now that we've got studies to actually validate this. So with that in mind, this is what the gizmo looks like. It looks just like a MitraClip. So you see this right here is the little clip that actually goes into the heart, grabs a couple leaflets, you pull them together, and then you minimize the regurgitation by opposing the leaflets. You end up maybe with some stenosis of the valve, so you have to be very careful with that, and that's particularly important on the right side of the heart because, again, the venous pressure is 10, 5. So you put something in the way, and all of a sudden that venous pressure goes up to 20. That's a big change. So you have to be very careful when you work on the tricuspid valve to not create tricuspid stenosis. The origin of this kind of technology, if you've ever heard it, is called an Alfieri stitch, where a surgeon back in the day would go into the mitral valve and rather than repair it by fixing things and rather than replacing it, they would simply take two leaflets and stitch them together with one little stitch. That's how the whole MitraClip thing came into existence. Obviously, the other technological challenge or procedural challenge with tricuspid valve is it's not a two-cusp leaflet valve. It's got three cusps. So you got to figure out how to do this without sticking 16 little clips in there. You end up almost always need two, versus MitraClip you can often get by with one. That'll make it a little more challenging, but it also means you're more likely to have stenosis. So it's tricky. How much does that help? So on this graphic, you can see at baseline, people had this red stuff, which is bad. Red's always bad, right? Everybody agree with that? Red's bad? So this is either severe or torrential tricuspid valve regurgitation at baseline. 30 days, here's your control group, here's your device group. So you're down to mild and moderate, and very little bit left with severe. When you do a different analysis, you end up with the same thing. So 1 year out, you can still retain good improvement of the tricuspid valve function, which is important. Again, this is very anatomic specific. You have to have the right anatomy in order to stick this device in and make a difference. So interestingly, again, as the surgeon showed over the years, death or needing tricuspid valve surgery, not a big difference. Heart failure hospitalizations do seem to improve. but not remarkably. But when they add things together, including how the patients feel, which again, I have seen that all these years, to me that still matters. If grandma has to sit at home and barely be able to elevate her legs and doesn't feel good and can't eat and is bloated all the time versus grandma going shopping and hopefully not buying McDonald's or Chinese, then it's still a win. And if it wasn't a major invasive surgery where there aren't huge risks, it's a win-win. Okay, so this is where the role comes in for this device. So 1 year out, again, improvement, and this is more of a graphic of if you improve tricuspid valve by even 1 grade of regurgitation, so from severe to moderate, or even 2 grades from severe to mild, makes a tremendous difference in these outcomes. Okay, so that's pretty well summarized. Sometimes they need pacemakers. The overall rate of risk is quite low. So that was the key to that. All right? So we had venous congestion problems. We know it causes inflammation. Tricuspid valves cause a tremendous amount of swelling and inflammation, which makes everything worse. And this is a tool that we will shortly have now that it's gotten through this trial. We'll probably start doing it here in, I would say, in the next year. I was just talking to Tuma about it the other day. So I'm pretty excited about that. Okay, now we hit the Arctic Circle. We're still going. And the road has turned to mud, getting back to Hat Nellis's reference to clear as mud. Sometimes you're in the mud. Okay, so let's talk a little bit more about cardiac cachexia. It's bad, bottom line. Okay? So the cardiorenal syndrome, there's this little CRS that you can hardly see, but it gets back to this notion of what happens and what's the oxidative stress. Acute decompensated heart failure, 80% present with congestion, 90% have renal impairment, and 50% have severe renal impairment. How much of that is reversible is part of the conversation. Either way, what's interesting is it's okay to take a patient's creatinine, diurese them, let's say it's 1.6, you diurese them and you get them up to 2.2. It sounds like a bad thing, but you're actually decongesting the whole system. And this is a study that showed if you have worsening renal function within limits, and I'll talk about the limits, then you actually improve the patient's outcome considerably. If you don't do that, they actually do worse. Okay, so remember, we actually don't mind having a little bit of a worsening renal function for the sake of the whole body. Congestion itself is bad. We already talked about that. What we were looking for in that, and I think I took this slide out because it was too complicated and there's enough small print that you guys have had to look at already today. But a 50% reduction in creatinine or increase in creatinine is okay. Once we start getting to above a 50%, that's when we start having more long-term tubular dysfunction. So cardiorenal syndrome is a big deal. Tricuspid valve is part of that issue. They're complex patients to take care of. That's kind of my take home from that. All right, now we got to the chandelier shelf, which is a nasty, muddy place, but we made it past. Okay, so I had to throw up one complicated slide because, again, we're in the mud. So this is muddy, and this is all about hyponatremia. I'm going to spend just a minute on hyponatremia. This isn't the hyponatremia of the little old lady who's just got bad nutrition and we can never figure out what's going on there. It's not the SIADH lady. This is a heart failure patient with a low sodium. And if you want to study this slide, feel free to do so. Dr. Hernandez talked about the I need help algorithm as to when to send people to advanced heart failure. In this discussion that I was involved in, they added the notion that if hyponatremia is present in a heart failure patient, that's probably also somebody that needs a little more advanced care, and you may want to put that on your list of people that you refer. In a heart failure patient, not every hyponatremia. I'm sure Dr. Purdy wants to see all the hyponatremia patients in the world, but maybe not. Okay, so it's bad, and these are the reasons why. It marks high risk for patients to come back into the hospital. It's a recognition of depletion versus dilutional hyponatremia that requires different approaches. So many times I see somebody send them home and give them salt pills. That really does, it might work in certain circumstances, but when we're talking about people with heart problems and heart failure, do not send them home and give them salt pills. That's not the fix. There is some discussion, they're doing research right now, of should you do short-term dialysis You know, we often say, yeah, we don't want to do that. We have to go through this really long conversation with the patient. Do you want dialysis? What if you get stuck on it long term? They all say no. But there may actually be some benefit to that versus just diuresing and diuresing and diuresing. I just recently, last time I was on hospital service, 2-3 weeks ago, I had one of these people, and I've seen it a few times before, where we just IV diuretics, give them the albumin, do all the things. They're not getting better. We went through the long conversations, and we gave them a total of, they were supposed to get 2 runs of dialysis. One of them, they dropped their pressure too low, so they only got 1 run of dialysis, and it was enough to kickstart an improvement. I don't see that very often, but it was one of those times, and I was very happy about it. Other reasons people get hyponatremia are on this list as well. So remember, that's an important marker. Okay, other reasons to send people to advanced heart failure. Some of these are obvious: end organ dysfunction, low blood pressure that doesn't seem to improve, but it's associated with a high heart rate. There's a difference between somebody who's hypotensive with tachycardia to compensate and somebody who's just hypotensive and is playing shuffleboard and pickleball. You know, they're 2 different kinds of patients. All right, I think that's what I really wanted to say about that one. Again, back to the concept of the sweet spot. How much diuresis is enough diuresis, where you get worsening renal failure versus improving renal function. It's all about taking care of that renal tamponade, getting it back to a proper fluid state. And then by that time, then you really do need to work with nutrition because they're behind. So once you finally get them diuresed, it's not the time just kick them out, send them home, say have a good day. You really have to get them involved with the dietary changes and get them on a stable regimen. There's lots of evidence to be seeing the patient within 7 to 10 days of discharge, because that's when we can make sure they got their meds, they're taking their meds, they're not going back to their old ways. Lots of data that you've all been familiar with over the years for that. This is a classic slide showing the cardiologist arguing with the nephrologist. There's even memes on the internet about that. So permissive hypercreatinemia, that's the concept. And this was the slide about the 50%. And then, yeah, if it goes up, this is a slide I'll let you look at later because it's kind of small print. But the concept is, how quickly did the creatinine go up, and then what does it do over time? It's a nice little guideline to look at. Okay, so good judgment comes from experience, and experience comes from bad judgment. I think we've all done both of those things, and hopefully we learn. I don't always agree that it's better to be lucky than good, because I think we try to be good at what we do. Okay, now we're at the Arctic Ocean. It's not as cold as you think. This is a guy from El Salvador that was up there. What the hell he was doing up there, I don't know, but why was I there either? Okay, so now this is a quick one, which is very important to me personally. I've spent a lot of my career dealing with venous disease, as I mentioned. And unfortunately, there's always this argument about what do you do with hip and knee prophylaxis for DVTs? Back and forth in the data. Is it aspirin? Is it Lovenox? Is it Coumadin? The Coumadin doesn't kick in for 7 to 10 days. It's just hard to know. So this was a nice study that basically said, you know what, we're going to do this again. We're going to do Lovenox versus aspirin with Lovenox. And not surprisingly, Lovenox was better. One of the old points that the orthopedists will say is, I don't want to do this because I'm going to bleed into my knee capsule. It doesn't happen that much, especially as we do things correctly with doses, and we're better at our rehab. So the short answer, the trial was stopped early because the DVT rate was so much lower doing the Lovenox than just giving them aspirin and sending them on their way. So that's an important trial in my mind. What's the number here? 3.45 versus 1.8. So that's a pretty significant number. And remember, 50 to 70% of all patients who have a DVT, for whatever reason, end up with long-term post-phlebitic syndrome. So it's not a benign problem. It's a bad problem. We don't want to have it. Okay, this is a place up there where everybody puts stickers. All right, another quick one. Low molecular heparin for thromboprophylaxis after a fracture. Similar study to what I just described. I've seen a lot of people that say, I never had a DVT. I don't know why my leg looks bad. I don't know why I had a PE. I don't know any of this stuff. And you find out when they were 18 years old, they broke their leg in sports. They ended up in a cast. And ever since then, that leg has been more swollen than the other one. They probably had a clot. So there's some data to suggest that you should do something. And at the end of this study, you can see aspirin and Lovenox were similar. So the short answer is, it's not to do nothing. It's to at least put them on aspirin and then try to mobilize the leg as much as you can. So that's an important study. Now we're just looking at the world from its different views here. This one's really quick. It's not a quick talk, unfortunately. I'm going to try to run through it, but we spent a lot of time talking about food as medicine today. So there's a whole subsection of the American College of Cardiology now devoted to this. I put myself on that panel for some stupid reason. But I'm going to learn things. And the concept we've already talked about a lot today. Here's a good trial from several years ago demonstrating the actual benefit of the Mediterranean diet and some other specific data for diets. This has been well studied, it is effective, and it's not only talking about long-term, morbidities and this and that, it's actually mortality benefit. So let's keep that in mind as we talk about this. All the different types of foods that we know are beneficial, soluble fibers, these things called polyphenols and related meds, phytosteroids, isoflavonoids, carotenoids, glucosamides, alkaloids. And then you don't want to do a lot of sodium and a lot of sugar. That's not surprising, but we keep saying it and patients still like it because instinctively our human body likes sugar and fat. Starches, cholesterol, nitrates, which is in a lot of our cured meats and various things like that, chemical additives. They talk about the biome. Well, this is the foodome. What happens when you eat certain foods? It actually can upregulate certain parts of your DNA to behave differently. So it's not that just you're eating a bad food. Cece's giving me the glare, but don't worry, Cece, we'll get through it. But there's actually different genetic expression based on what you're eating, which was surprising to me. Okay, so keep that in mind. It's not just that it's what you're eating, but it's how it's changing your body and also changing that biome, which, as we all know, we are symbiotic with our bacteria. So depending upon what we eat, it actually changes how the bacteria behave, which then also has an upregulation and downregulation effect on our bodies. This was an important slide that I wanted to bring up. So here's tobacco, okay? And here's high systolic blood pressure, and here's body mass index, and here's fasting glucose to Dr. Saini's point. Well, look at where dietary risks are. If we have a poor diet, and this has to do with bad choices, but also people that live in food deserts, it has to do with health equity, which is a big topic these days, you have to really focus on the diet to the extent that it's probably more important than the smoking, which is hard to believe coming from, our point of view is what we do. But keep that in mind. What is a bad diet? It's low on fruit, low on vegetables, low on legumes, low on whole grains, low on all the things you would want, high on processed meat, high on sugars, low in calcium, and the omega-3s, etc. So the difference being globally, there's a 22% dietary cause of CV mortality considered, and in North America it's 18%. We're not a lot better than the rest of the world, even though a lot of the world is not as advantaged as we are. How much does that cost? $1 trillion a year spent on healthcare that's directly related to a bad diet. So these companies are making a lot of money selling us the foods that we instinctively want to eat. So fine, Cheesecake Factory exists and it tastes good, but they're making money off the fact that we're then doing bad choices and it ultimately ends up costing us $1 trillion in tax money. That's a lot of money. That's a lot of money. This one I'll skip through, but it has to do with low socioeconomic determinants and how that affects the diet and the choices we make and the support we have. It's a very nice slide to gander at. Now, healthcare industry is starting to pay attention to this. There are a variety of different interventions that are even coming to light within value-based care versus standard HMO care and other types of care that we have. So we're going to talk about that a little bit. There's a whole category of medically tailored meal programs, which I don't even know that we have around here, but you can basically have food sent to somebody's house. That's the right kind of food. All the way down to what happens at the national level with the agricultural department and everything else. How do we guide the ship from a legislative standpoint? And unfortunately, a lot of that is based on who gets more money and who has a special interest. But really, that's not our problem as healthcare workers. It's how do we get them to the right things? I mean, most of the people in the room, if I give you a piece of cheesecake versus a pile of salad, you're going to kind of want the cheesecake. So it's tough. Higher level of intervention being the medically tailored meals, all the way down to things that are basically getting people to reasonable food and improving food security. The farther up you go on this, the more beneficial it is to the patients that need it. To that point, we have WIC and we have SNAP, which actually have strong evidence for improved long-term outcomes. If people need it, they should use it. That's why it's there. So this one, yeah, I think I'll skip through this. It's all about how much money you save when you do these things correctly, and there's also a reference at the bottom for those that are interested. Easily spend $100 billion less in healthcare if we start using what we already have legislated. So just enacting the things we already have, encouraging what we already have, would save us $100 billion. Thank you, CC. These are some of the stakeholders in this who are trying to push for better food. It's surprising to me that one of them is Kroger. I don't understand where that's coming from, except that maybe they're involved in sending you the food. But I'm glad it's there. Legislative action happening at the federal level and the state level to work through these things. They're very important. I can't imagine how much benefit we could have if we would use these things, and as we have to continue to move forward in the legislation. Please be aware of these things. Nothing happens without the government saying so in some respects for our underprivileged people. Again, no money, no mission, and then we can talk all we want. We can spend an extra 10 minutes with every patient in the room to go through these things, but if they don't have a program that'll help them, we're not going to be able to help those that need it most. So let food be thy medicine and medicine be thy food, from Hippocrates. This one's my favorite. For years we've said we can't stent our way out of this, car wreck or train wreck that we've been dealing with, where we fix people at the end of this process. But we also can't Ozempic our way out of this. We have no data for it. We know it helps people. We're starting to get benefit to blood pressures and sleep apnea and blood sugar levels, and we're starting to get data on mortality, but it's not really the solution, as been discussed earlier today. You're on Ozempic or Mounjaro, you're basically on it for the rest of your life, maybe? I mean, that's just not cool. So we got to keep working on all components of this. Here are some other basically links that I wanted you guys to have for education on these things. And here are a couple of websites and monograms that probably would be beneficial if you want to get a hold of them, put them in your clinic, have people read them. It's hard to get things in front of people anymore, but it's a good example of things that may or may not be helpful. More links, they'll be available. All these talks, by the way, are recorded and available through our system. This is the good old plate chart, okay? So how much of your plate should be pastas versus proteins versus other kinds of things. It's still a good chart. After all these years, it's still helpful. You show this to a patient and they're like, yeah, I don't do anything like that. It's very helpful. This one, if you want to scan real quick, it'll pull up some helpful resources. It's just a 2-page thing, so if you're going to grab your phones and do a little QR code on that, it'll get you what you need, and I'll show you what it pulls up, but it's a nice resource. Give everybody a chance to do that. Lots of phones up. All right. I think we got everybody. Okay, one more person. Okay, so it pulls this up, and it's a nice concept you can review with your patients. More links. This is a ACC toolkit which they're developing, which is again something you can reach through the acc.com Food is Medicine links, and it'll give you, again, a program you can implement in your own practice or in your own advice to patients. Is this an ethical imperative? This was part of our discussion when I was at our meeting last Sunday, this last week in DC. And do we simply have an obligation to make this happen, and then how do we do that? You could make the argument, people need to find their own way to have a healthy life, but at the same time, as healthcare workers, how do we make that feasible for everybody? And I think that is an ethical discussion. I'm not sure I know the answer, but it's definitely an ethical discussion. This is an example of what one of the governors in Nevada did. She's the ACC governor in Nevada. She started a project where when you go to get your food, you're given these buckets, and you have to buy, you're advised to buy this much of this kind of food, this much of this kind of food, this much of this kind of food. I'd love to see something like that happen around here, particularly if people are on WIC or SNAP or whatever else. Okay, summary-wise, poor diet quality is the #1 killer in the US and globally. It's mediated through cardiometabolic diseases and creates a massive economic burden that nobody can afford. Lots of data, lots of nutritional insecurity around the world, and particularly in our country and in our local region. This is one of the things that I talked about with our legislators. We have one of the poorest counties, if not the poorest county in the country. And they live in a food desert. We've got to do something about that. Okay, here's a picture of a beautiful lake coming back south. Fireweed. Okay, this one real quick. When any one of these issues, whether it's heart stuff or even whether it's the politics around how we handle these patients and their issues socially, you've probably all seen this before. When you look at an elephant, if you're only looking at one part, you think that's the whole story. You got to get together with everybody. You got to talk about all of healthcare. Primary care docs know this better than anybody. They have to look at every piece of that patient's outcome. In cardiology and vascular disease, we look at little pieces. You know, EP looks at even smaller pieces. It's all important, but we all have to work together. To that point, I was going to call this a quick word from our sponsors, which is tongue-in-cheek, you know, peripheral arterial disease creating a financial burden. But remembering that peripheral arterial disease is associated with high morbidity. We have legislation currently about how to do better screening and what the associated mortality rates are from doing better screening for PAD. Polyvascular disease we talked about last year. I don't think I'll go into that. So this one is just briefly touching on the fact that there was good data on using Xarelto at low doses in our cardiovascular patients. It's now important for coronary patients as well as peripheral arterial patients. The Voyager trial and then the subsequent Voyager trials after that, so keep that one in mind. Teams. I wanted to talk about teams for a minute. It's a team sport. I mentioned that. Everybody in this room and online, it's important to function as a team, to communicate, to be respectful of each other, to work with things. Cece's telling me as my team member that I'm out of time. Thank you, team member. Trust your team. And now this slide is important. These are a bunch of the leaders of the American College of Cardiology. This lady was the chair of the Board of Governors last year. This is the current chair. And our upcoming president of the American College of Cardiology, the president of the whole thing, is a nurse coming up next year. First time ever. She's Mayo trained, Mayo experienced as a CCU nurse, and then went into the, I don't know what you want to call it, the consulting side of things, and has been running some groups in Illinois and trying to coordinate care. She'll be a tremendous gain. She's an MSN. I know there are some people who've had negative experiences with the ACC, but it's been for the last 15 years trying to get more engagement in the cardiovascular team. I think she's going to be great to keep moving that forward. So I'm happy. Her name is Kathy Biga. She's a great lady. More pretty pictures. That I'll skip. Dr. Purdy talked about this, but for his benefit, Million Hearts, priorities. Okay. All right, pretty pictures. And then I went to a wedding. My daughter got married. That's the end of that. All right.
Questions, anybody?
Why do you inspect the feet? So the best indication of peripheral arterial disease or venous congestion or anything else is everybody does their exam. Some people were taught top down. I've always practiced bottom up. And it's been well validated that if you look at a patient down there, you feel for your peripheral pulses, and you look at the quality of the skin, you look for the congestion, it gives you nutritional input, then you work your way up. Then you won't forget about the liver and the spleen on the way up. You won't forget about the aneurysm you're supposed to inspect for when you're feeling the belly. So if you start there, work your way up. It's kind of like, you know, when we're taught to look at a chest x-ray, everybody looks at the chest x-ray, we quickly look at the lungs, and then we move on. But the radiologists are taught, look at the bones, look at the vascular structures, look at the mediastinum, leave the lungs for last. It's the same concept. Look at the things that you're least likely to pay attention to because actually they have a lot of golden opportunity for figuring out the patient. Thank you. Yep.
One comment first is neurologists do it in the opposite order that you guys do.
Yeah.
Start at the top and work down.
Yeah.
Other thing is, how do you keep people from eating more when you're pushing healthy foods on top of all the junk that they eat already? I mean,
Right.
the problem in our country is not eating more, it's really eating too much.
Right.
We got to push eating less.
Yeah. I love Dr. Hattonellis's point that if you give them a little bit of instruction of what the human instincts are and who's making money off of our bad habits, it starts opening a little bit of a ray of sunshine and light for what comes next. Beyond that, if you make good choices and most of your plate is a big pile of vegetables, you're going to be full before you get to your cheesecake. And that's the idea. What else we got?
Okay, thank you.
All right. Thank you very much, everybody.